Hello, everyone. On behalf of NCOA, I'm here to introduce this session titled Community Health Workers for an Aging Population, Leading Change in Community-Based Service Delivery. We are very pleased to welcome you today. My name is Michelle, and I will be your moderator for this session. I encourage you to participate by submitting questions and comments in the chat area down below. We will address as many as we can at the end of the session. Also, all attendees will be on mute during this session. It is now my pleasure to introduce today's presenter, Stephanie Stewart, who is the Aging Program Specialist with the Area Agency on Aging at Land of Sky Regional Council. Now, let's get started with Stephanie.
Thank you. So I am Stephanie Stewart. I'm with the Area Agency on Aging at Land of Sky Regional Council, and I manage the evidence-based health promotion programs in a 4-county region in the western part of North Carolina. I'm also the developer of the Asheville Terrace Community Health Worker Initiative, and it's a model specializing in community health worker services for older adults. My interest in community health worker models stemmed from difficulties I had engaging communities with high disease burden and low access to resources in the evidence-based health promotion programs. These communities face complex social and economic challenges affecting not only individuals, but the community as a whole. And health education just didn't seem to be the right focus or fit for these communities, facing consequences of things like generational poverty, structural racism, and institutional betrayal. Though health education does have a part, I was already working with lay-led peer models like the Chronic Disease Self-Management Program and A Matter of Balance. So I wanted to expand on that and dig into some long-term sustainable change for better community health. So we're going to cover a lot, and it's going to be very broad strokes. What I really wanted to do was focus on the unique features of community health worker initiatives that really differ from traditional approaches to offering aging services or health programs. So a lot of what we cover is going to be, again, unique, but I'm only doing an overview. So we'll start with the community health worker definition. I'll talk about our program's initiative, or our initiative's purpose. I'll quickly review some milestones. I'll then discuss the organizational partners. So we've really built this strong clinical community partnership. I'll talk about how to recruit the right people as community health workers, how to train, supervise the community health workers. Then I'll talk about our process for planning and implementing services, as well as scope of work, and then how we evaluated our services, some resources for funding, and then some additional resources if you really want to dig in and do a deeper dive. So the American Public Health Association defines community health workers as frontline health workers. They work in systems which shape individual and community health. They're producing change at individual, interpersonal, community, and societal levels. They're also trusted members and or have an unusually close understanding of the community served. So community health workers work in and with communities that have histories of disenfranchisement, often communities of color, immigrants, low-income neighborhoods, and rural communities. So their trusting relationship enables the worker to serve as a liaison, a link, an intermediary between health and social service and the community. So community health workers are advocates for their communities. They're going to correct misinformation or stigma. They're going to create a deeper understanding of the community, empathy, and they're also going to illuminate the community's assets and build capacity from its strengths for more sustainable collaboration with these institutions. They also improve quality and cultural humility of service delivery. So services the community health workers are offering are relevant. They maintain the values of autonomy and integrity for the service recipient. Our purpose with the ATCHW Terrace community health workers is to improve the lives of high-risk, under-resourced older adults living in public housing. We do this by facilitating networks of support. Our work started in 2017, and we've reached many important milestones along the way. In the first year, we completed community health worker core competencies training. We conducted community assessments, which informed our service development. And we established relationships with providers and community members while promoting ourselves as a new resource partner. A lot of individuals weren't familiar with the term community health workers, so we really had to spend a lot of time explaining what it was we were hoping to accomplish. In the second year, we focused on service delivery, which included testing new programs and methods of delivery, evaluating successes and challenges, and adapting for improved results. We also worked on expanding our capacity by recruiting community volunteers, and we also developed processes for partnering organizations to refer to our services. In the first year, most community health worker support was provided by self-referral. We also identified needs and desired roles for our clinical partners. In year 3, we continued offering services as well as creating and modifying new programs. We formalized our clinical partnership, and the community health workers began supervising volunteer-led programs. I also began pulling together a lot of documentation, our planning materials, research I did initially when writing the grant, meeting minutes, and what I really was hoping to do was to document our successes, challenges, and processes. I wanted to create tools for others, and so others could learn from what we were doing and potentially grow the model. And I also wanted to prove eligibility for new funding sources. So I'll talk more about some of these products later on. And entering year 4, we have exciting news. Our funding this year will be through North Carolina Home and Community Care Block Grant, which is North Carolina's allocation of Older Americans Act funding matched with state dollars. So this is creating a new pathway, a new funding pathway for community health workers that's going to be accessible to aging service providers across our state and potentially other states through Title IIIB. So our organizational partners and their roles. Our community site is Asheville Terrace Apartments. It's managed by our Asheville City Housing Authority. There's 248 units dedicated to housing low-income, older adults, and adults with disabilities. Our clinical partner is Mission Health's Accountable Care Organization. They serve our region's Medicare population and aim to reduce emergency department visits and rehospitalizations. And the program management is the Area Agency on Aging at Land of Sky Regional Council. And our fit is that we coordinate a regional and local system of aging services. So the role of the AAA I manage the grant. I train and supervise the community health workers. I facilitate planning and collaboration with external partners. And I manage data and evaluation. Both the clinical partner and community site have similar roles. They attend monthly team meetings. They consult with the community health workers to improve both community and individual client support. And they refer neighbors to the community health workers' services. Mission also contributes in-kind resources by providing on-site clinical services. And the Housing Authority contributes financial support. They purchase supplies for various events and programs, and they work very closely with the community health workers in a variety of ways. As you can see, community health workers are at the core of this partnership, and they're really steering the collaboration. So before we could start this work, I had to find the right people. I couldn't rely on traditional methods of recruitment, and what I found was recruitment of the right people requires active, deliberate strategy in place of passive recruitment like posting on job boards. So I started by finding a bridge person. I approached the Asheville Terrace Service Coordinator with my idea and asked if she could recommend residents who might be interested in participating. Then I also provided her with a job description, information on the grant, and the planned compensation for community health workers' efforts. She then relayed this information to the folks she recommended and scheduled a meeting for us to meet and discuss. So it was a warm introduction. Additionally, I led a Matter of Balance program on site as a way to introduce myself to the community and the community health workers. So it was a very intentional relationship building and introduction. What qualifies community health workers to perform this work, it won't be found on a resume. Instead, personal referral, like finding a person already embedded in the community, like the service coordinator, or evidence of altruism or volunteerism can demonstrate a good fit. A candidate should have shared attributes to the community served. They should share personal values that align with the work, like social justice and health equity. And they should also have personal traits that facilitate relationship development and demonstrate leadership, like trustworthiness and compassion. So these are Asheville Terrace community health workers. When I asked both Mary and Susila why they thought the service coordinator recommended them for the work, Mary said, "I'm always interacting with people." Mary's a lead cook at the Welcome Table in downtown Asheville. She's been feeding Asheville's homeless population for many years, as well as many Asheville Terrace residents. Susila said, "I'm reliable. When I'm given a job, I get it done." Susila worked directly with property management to support neighbors' transportation needs prior to training as a community health worker. After we had the core team members recruited, it was time to train. So community health workers have an intimate and personal understanding of the communities they serve. The training complements this knowledge and introduces skills and concepts to expand on their impact. So there's a few resources, or a couple resources I have listed on this slide. The C3 project is a great resource for exploring best practices for national perspectives. And I chose to use the Foundations for Community Health Workers text and training guide to deliver our community-based core competencies training. It's a well-developed resource used and developed by students and faculty at City College San Francisco. And the training guide includes videos, interactive exercises, and is free to use with proper citation and purchase of the companion textbook. There's some examples of training topics also on the right side of the slide. And again, links to the resources I mentioned on the left. And while it was a big commitment and investment of time, learning content and leading the training myself really better prepared me to supervise the community health workers. I'd done a lot of research on the front end, but doing the training myself really helped facilitate rapport and authentic team-oriented relationships. So I would highly suggest a supervisor also at least co-training. And supervision. So supportive supervision is a leadership style that fosters community-led change, which is what we're trying to accomplish. It takes a team approach to decision-making and problem-solving. It focuses on the community health workers' strengths and builds from them. And a good community health worker supervisor is also aware that community health workers likely face many of the same challenges they're working to resolve in their communities. It's been important that I helped the community health workers I supervise create boundaries between their work and their life. I've consistently encouraged self-care and reflection and tried to stay sensitive to burnout and frustration, and providing additional support or helping to find community resources for the community health workers for their own needs. So going back to my original interest in community health worker models, I intentionally sought funding that was flexible, that didn't box us into providing a specific program with a narrow focus. The goal was to develop relevant, meaningful interventions, and it started with information gathering. So community-focused planning builds from community strengths, and it's more sustainable. I not only wanted to look at community needs, but again, the assets. We built from the ground up, but quickly. This wasn't a planning grant. It was do it all in the first year. So we incorporated our first community assessment into our community health worker core competencies training. Started by tapping into community health worker knowledge. The community health workers, as key informants, have valuable insights. We brainstormed resource deficits, community strengths, and ongoing concerns. We broadened our understanding with community input using surveys, interviews, community forums, and making sure to appropriately incentivize. We also were very cautious not to over-survey. This is people's homes. It's not a research study. So we wanted to make sure that we were continuing to build rapport, but collect the information we needed. We then collected all of the data and compared information to prioritize interventions. So we grouped common ideas and looked for overarching themes. And areas of focus for intervention were chosen based on likelihood of success, resources and capacity, degree of impact, energy and interest of the community health workers. So the next step, be inclusive from the start. We began with a large community event and made sure to have activities that engaged many interests. So our very first community event was the Health and Halloween Fair. We offered food, games, prizes, resources, flu shots, health screenings. We didn't want it to be a dry event. Again, we're trying to build social networks. So we are pretty consistent with making health education or any kind of program or service fun. And we learned a lot about interest simply by observation. So it doesn't have to be only surveys, but as we were providing community events, informal interviews, getting feedback, and observing what folks are participating in. Personalized support to individuals also provided anecdotal information that revealed a lot about an individual's environment. And evaluation is a constant part of the process. So for community programs, participant attendance and feedback informs how, when, and if a program should be adapted. With personalized support, team meetings and supervision provides the space to problem solve challenges and concerns. And evaluation and adaptation must be a continuous part of the process. Again, our community has many complex needs with deeply rooted causes. It's constant adaptation and movement with what we're offering and what the issues manifest as. So staying community focused is important to understand root causes for many of the community's more insidious challenges. Promoting health at an individual level is counterproductive if an individual's environment is chaotic. So community organizing is a tool to establish those networks of support, undergirding individual well-being as well as community cohesion, but it's difficult when the community has a legacy of trauma. Weinstein, Wolin, and Rose define community trauma as the collective effects of violence, crime, concentrated poverty, racism, and structural disenfranchisement. Community organizing in these very communities is an essential community health worker function. Trauma-informed community building does not try to treat community trauma, but instead it acknowledges trauma's influence on behavior and avoids re-traumatization by following established principles. So some of the principles: do no harm. Intervention should be sustainable and not short-lived. Acceptance. Organizers must meet community members where they are and not set unrealistic expectations. Community empowerment. Organizers should always include and acknowledge community participation in decision-making. And reflective process. Organizers must adapt to the community's changing needs and priorities. So meaningful application of trauma-informed community building principles address each level of the social ecological framework, reflecting community health worker training and practice. The social ecological framework takes a dynamic multi-factor view of health, recognizing influencers at an individual, interpersonal, community, and system level. Asheville Terrace community health worker examples of practicing these principles at all of the levels include the individual level. We incentivize individual participation and reinforce experiences of self-efficacy. At the interpersonal level, we leverage peer support and modeling. At the community level, we celebrate milestone achievements and focus on incremental growth. At the systems level, we really have tried to work to secure long-term investment from community partners. The scope of practice creates parameters for service development. So understanding what it is we want to accomplish, we also need to understand how we can effectively go about it. Community health workers are not all things for all people. They are most effective when given structure to practice within. So the community health worker scope of work or scope of practice brings clarity to roles, right sizes expectations, and again, establishes parameters for professional and ethical service delivery. For community work, in the scope of practice, we included that community health workers can collect information to assess community issues. They can coordinate resource and/or wellness activities. The community health workers can recruit and manage community volunteers. They can advocate for community needs. They can build relationships with community and clinical organizations, and they can lead exercise groups, healthy cooking demonstrations, and evidence-based lay-led programs. For the individualized support, community health workers can communicate with service providers upon request and with permission. They can provide medication reminders. They can offer information about community resources. They can make social visits to homebound neighbors and provide peer counseling to encourage healthy habits. They can make reassurance visits or safety checks for frail neighbors and those recently discharged from the hospital. And they can also refer to outside services and supports. Perhaps more important is to identify what falls beyond the community health worker scope. Each community health worker initiative is going to have a different focus, so what falls in it may be different, but what falls outside of it is going to be the same across the board. So we were clear to describe what community health workers cannot do, including community health workers cannot provide personal care services like housework, bathing, toileting. Community health workers cannot manage medications or perform services requiring a clinical license. Community health workers cannot diagnose or prescribe health treatments. Community health workers cannot charge for services or accept donations. And community health workers cannot give legal or financial advice. So measuring outcomes was an important piece as well, evaluation, and the Asheville Terrace Community Health Worker Initiative uses the results-based accountability framework to evaluate our program's performance. So RBA is a practical tool for measuring program features valued by staff and managers. It uses clear language and simple methodology to illustrate if and how clients are better off as a result of participation. So Asheville Terrace Community Health Workers' vision is for all Asheville Terrace neighbors to feel safe, connected, and cared about. So using the RBA framework, program performance evaluation is based on these ideals and follows the questions, how much? This question quantifies outputs. So Asheville Terrace Community Health Workers track outputs as the number of services provided. The question, how well? It addresses quality of outputs. So what features of the program or service demonstrates improved quality? Asheville Terrace measures quality by counting number of resident volunteers contributing and variety of service mix. For the question, is anyone better off? This question looks at service efficacy. Does the effort make a difference? Is it working? For quantity of effect, Asheville Terrace Community Health Workers track number of people attending programs and number of repeat customers. For quality of effect, we track percentage of community participating and percentage of community as repeat customers. So some of our outcomes. In the 3 years we've been doing the work, we have continued to increase the number of unique individuals served. Of the 248 units, we've not been able to track resident turnover, but you can see a reach of 256 for FY20 as a clear engagement, a clear sign of high engagement. And these numbers are only going from July 1st through mid-March, so this isn't our full year. So community programs, we created categories to measure a type of community work, and these categories include health groups. So health groups are small, shared interest groups, activities led by a community health worker or community volunteer. This could be a movie night, it could be a gardening club, it could be a walking group. Health events are health education or services provided by an outside professional or organization. So we have had drop-in clinics with pharmacists, with social workers. It could be mental health education in a group format. Social groups are small shared interest group activities led by a community health worker or community volunteer. So I'm sorry, the gardening club is more a social event, the walking club is more a health group. Social events are large social activities often involving a meal or food. So we've definitely recognized food insecurity as an issue, and so addressing the underlying need for nutrition with a social event or even a health event is a way that we engage folks. Health fairs we offer twice a year to provide health resources, collect resident feedback, promote new services, and celebrate community. And our food distributions, again, are one of our most popular programs and services. Residents choose fresh produce, dairy, meat, and staple items. And then for residents who have mobility issues or are homebound, we deliver groceries bi-weekly. While programs are well attended overall, with approximately 13 registrants per event on average, there are differences by program type. So health fairs, food distribution programs, and social events lead the way with roughly 50, 40, and 21 residents per event on average. The volume of programs and participation truly is staggering, where in fiscal year 20, the community health workers have already coordinated 298 community programs with 3,496 event registrations. And again, the fiscal year 2020 numbers are only through the month of March. A majority of our residents keep coming back. So 61% have participated in events 2 or 3 of the years the program's been running. And our resident population is evenly split by attendance behavior. So approximately 50% of residents are moderate to heavy event users, meaning they participate in more than 5 events each year, but the other half are light users. So we're trying to improve consistency with engagement, but are still excited that we have engaged a large portion of the community in at least 1 to 5 events. So we're talking about community programs for the personalized supports. Categories for work with individuals include reassurance checks. So this is risk identification and safety checks for frail residents concerned about falls or injury. Our neighborly visits are social visits with informal assessment of mood and general well-being. Health management support may include medication reminders, promoting physical activity, goal setting, talking with service providers, or blood pressure checks. And transportation may include trips for shopping, medical appointments, or health-related errands. We don't offer transportation widely, but for the individuals that are frequently requiring personalized support, our community health workers will provide transportation. So home visit services have steadily increased year over year as our community health workers became more confident in their role. They also were cautious to provide too much direct service without the necessary support from our clinical partners. They didn't want to come into a resident's home or a neighbor's home as a resource for support and not be able to follow through. So we wanted to make sure that as we identified higher needs, we were able to refer and provide that. And volunteer commitment is strong. Since fiscal year 18, our volunteers are doing more activities per year. And about 2/3 of residents report that our programs and services seem to be making a difference. Ways residents see community health workers making a difference in their community include a variety of testimonials, keeping everyone safe, sympathetic, caring, and sharing for the needs of the community, has informed me on a great many things in and out of the building, motivates people and people moving around. By keeping in contact with residents, the workers have been able to spot problems early, provide activities to entertain, inform, and enrich the lives of the residents. Let residents know they are cared about. Knowing someone is here to assist you when you're sick, to help keep you from panicking, and sense of more connected, warmer community. Funding for community health workers has predominantly come from public sources, frequently in the form of grants. However, funding streams have become more diverse and include private foundation grants, state allocations, state Medicaid policy action, Medicare managed care organizations and advantage plans, and now in North Carolina, Title IIIB Home and Community Care Block Grant. Elaborating on the last bulleted point, we as aging service providers have access to funding that fits the community health worker model. The Older Americans Act was created to support older adults' abilities to thrive in community with choice and integrity. The Older Americans Act also prioritizes services to communities disproportionately affected by poor health. Community health workers aim to improve access and engagement in services for those most in need of support. And as we come to an end, I hope you're encouraged to explore opportunities to partner with community health worker organizations and/or opportunities to onboard community health workers in your own organizations. I have a few resources listed here, including information on the Foundations for Community Health Workers text, the C3 project for training, and results-based accountability. It's a very adaptable framework for evaluation of any program, but we especially appreciated it for our work. And going back to the development of tools and resources, I have a few Asheville Terrace community health worker specific resources I'd be happy to share. We've created a data management toolkit, which is a quick reference user guide and a template Excel workbook for how we tracked those community and individual programs and services. I also recently created a planning guide covering a lot of the information that I have reviewed in this presentation with a bit deeper dive. And both of these resources are available. I offer them freely and hope that folks can learn more and, again, possibly grow this really important model. And that is what I have. I guess we can move to any questions you might have.
Thank you so much, Stephanie. If you have any questions, comments, please share them in the chat box. I do have a couple of questions that popped up as you were presenting, Stephanie. I received a lot of questions on whether or not they can receive a copy of your presentation as well as the notes, Stephanie.
Absolutely. Again, you could reach me at the Land of Sky email address or the Asheville Terrace, and I could send any of the resources, including the presentation.
Awesome. One person commented and said, "This is really fantastic work," and it really is, Stephanie.
Thank you.
Another person said, "Fabulous presentation." One person asked, "Is it important for community health workers to be older adults themselves?"
So that's the model I was using, and I guess what they have found nationally, there's a lot of work being done to research the workforce development piece. I believe the majority of community health workers are middle-aged, the ones that are actively working as community health workers, but and for my model, I wanted to use residents in the low-income senior housing community, so it was important that they were older adults, but across the board, it's not.
Perfect, thank you. Another question we have, are community health worker programs only available through the AAA?
Oh, not at all. I believe I was specifically trying to bring this model into AAAs. So they are more frequently hired and working in federally qualified health centers, on interdisciplinary clinical teams, but a lot of community-based organizations, a lot of nonprofits, and some states have allocated funding to use community health workers in state health departments.
Perfect. Many more compliments, Stephanie, from Patty. Nicely done. What great outreach and involvement in the community, making a difference through trusted members of the community. Great outreach. And then from Sharon, impressive presentation, and we will go to school on you. A couple more questions just came in. From Kathleen. Stephanie, thank you for the very informative presentation. Would advocacy for advanced care planning or advanced directives fall within health management support role of community health workers? For example, promote group classes or referrals, be trained advanced care planning facilitators in the community.
Absolutely. So the strength of coming from a AAA is I have relationships established with a lot of the service providers in our area, so I've been able to pull in resources. So we did have an advanced care planning talk where we had about a dozen residents come, and they even completed forms, and they there was a the person who signs off and makes it official. I'm sorry, that's I can't remember the term, but yes. So we are frequently we're open to what organizations might want to bring in, but we also I run everything through the community health workers to make sure they believe it's a need for the community. And I sometimes challenge them on opening their minds a bit. We've had some presentations on older adult sexual health, which was uncomfortable initially for community health workers, but we found it really useful and well attended.
Good. A question from Mary. Would you consider this model similar to peer specialist, or is it significantly different as it is a community-based rather than individually focused?
Right, so it's very similar in community health workers having those shared experiences or histories, though it's broader. So this model is really looking at social determinants of health. So there's definitely that individual direct service component, but it's a public health model, so we're looking at all of those layers and levels. So how can we look at changing systems and do some advocacy there to improve those community level outcomes, same with community level, interpersonal. So that's, I guess, what really makes this model pretty unique. We don't limit it to just working one-on-one, but we're really trying to have a broader change.
Perfect. What has the average cost per year of the two community health worker and the supervision been?
Mm-hmm. So initially, to get grant funded, I was I applied for a smaller amount. So we've just about tripled our grant now, and it's still significantly small. So initially, I was using the CSEP program to pay the community health workers. I wanted to make sure that we were reducing risk as well, because we were literally building the plane as it was flying. So community health workers were paid using CSEP for the first year and a half. We also had to do some research. So one of the community health workers is on Social Security disability, and the other is on retirement. And they're living in subsidized housing and have other benefits they're receiving. So we chose to use a stipend. I did a lot of research on what would be an allowable amount and wanted to stay under the amount that would jeopardize any of the benefits they're receiving or financial support. And then it's taken about 10% of my full-time. The community health workers really have done all of the work. I have kind of been the structure and, again, connecting to resources, but they're phenomenal in what they do.
Perfect. Another question is that I heard that you created curriculum for the community health workers, but did you work with a specific university?
So there's been a lot of focus on training, and there's a lot of resources. And so in the state of North Carolina, there's been a work group going back to, I think, 2014, where we were researching training and curriculum and core competencies in other states. And so we developed a suggested core competency standard for our state. The Foundations for Community Health Worker curriculum has been around for over a decade. It really covers everything. And so I didn't create my own curriculum. I truly used again, that free resource, the training guide, and adapted the activities to fit our population of older adults. There were videos, activities. It was very interactive. So most of the training was doing a little bit of lecturing and a lot of practice in real time. So as we were learning about effective community outreach, we were performing outreach for different programs and services. As we were learning about how to conduct community assessments, we were performing it. So we really extended the amount of time to train over a year. So we met once a week for 2 hours, and that included our team meetings, our planning, and some skills building. I kind of didn't know what I was doing, so I wanted to be really thorough, and it's just really turned into something amazing. But I would highly suggest looking at that curriculum. The Foundations for Community Health Workers is very comprehensive.
Yeah, especially if it's already available and it's working. Why not take it and adapt it in your own community? Yeah, of course. Um, can you please describe Land of Sky as an organization? What else do you guys do?
Right, so we are a regional council of government. So we have our some of the other departments outside of the Area Agency on Aging, workforce development, economic development and planning. We have transportation. So I guess a lot of the federal program dollars come to the state and go out to the region. So we are really do a lot of funding for public programs and services, and then the monitoring. In the AAA, we do more direct service as well. And our organization is very innovative and supportive of exploring and trying new ways of doing things.